Hi guys, Enoch Gramuza again. Today we're going to be focusing our session on health financing for universal coverage. This is um, an important session, especially coming after the human rights lecture that you had with Professor Agnes. So we're going to build on that human right aspect of health being a human right, and then see how do we make sure that everybody has the healthcare that they need without suffering financial hardship. So today we're going to be looking the overview. We're going to briefly talk about universal health coverage, what it is, and the definitions and all that. And then we're going to look at health financing as a tool that's used by health economists to kind of how to implement a universal health coverage. And we're going to go through that. We're going to go through the health financing functions, and then we're going to look at some examples as we look at the functions. A lot of these functions, we're going to kind of like try to make them understandable and relevant by giving really good examples. So, about health, universal health coverage, we know that in 1978, we the world gathers in Alma Ata, and they decide that there should be comprehensive primary health care. Health should be guaranteed for all, for everybody, and it should basically coming to this point that health should be a human right, and everybody should have a right to health and good health. So this dies down in the with the rise of neoliberalism as we've seen in the past. And then in the 2000s, we started seeing the health for all movement come back. So it came back, but they started to do things. This is where the AIDS epidemic was going on, and people were starting to see that people should be afforded the good health that they need. And then in the 2010s, we 2015, we saw the SDGs go into effect, and the world is basically saying that by 2030, we should have achieved all these goals. And I think a lot of countries are on track to do that. But one of the SDG number three, as you know, is good health for all. So, what does that mean? In order to explain that, to make sure that everybody has good health care, there's this concept of universal health coverage. So, universal health coverage, this is a box a cube that's usually used to describe it, and it's by WHO. But basically, what you see here is basically three components when it comes to universal health coverage. So you have the component of the population, so that means who's covered. You want to make sure that you have as many people covered as possible. So is everybody covered either under an insurance plan, or is the country covering all the people? Does everybody has some type of coverage? So that's the population aspect. So then there is the services aspect. We know that countries can't be able to provide all the services in the world. We know that resources are limited, but countries try to make sure that they provide good enough quality services and make sure that all the priority services that are needed by the population, and this differs from country to country. In one country, malaria can be a huge problem. In another country, diabetes is the problem. So it depends on what the priority need for that country. So, but that's the service aspect or component. And then the direct cost component or the cost component. One of the things that the universal health coverage tries to do is that people, when they're purchasing health services, it shouldn't matter if they're able to purchase it or not. They should be able to get all the services that they need without suffering financial hardship or without going impoverished. So that's the three components we have: the services component, the population who's covered component, and then the financial component. And that's basically how the countries try to ensure universal health coverage. So in words, there's three components that I've put in blue. So you have to make sure that there's equity in access to health services, which means everyone who needs services should get them, not only those who can pay for them. So that's the equity in access. Um, and that comes back to the population aspect that I was saying, who's covered. It shouldn't be just the people who are able to pay for them, or the people who only live in the cities and all that. So it should be equitable across the country. And then the quality aspect, the quality of health services should be good enough to improve the health of those receiving services. So a lot of the countries can be like, oh, we have health centers in all the country, but that's not enough. You have to make sure that those services that are provided at those health facilities that are in the rural areas are also providing quality services, or good enough services to improve the health of those receiving them. And then this component, protection against financial risk. So it means that people should be protected against financial risk, ensuring that the cost of using services does not put people at risk of financial harm. If I want to buy or to purchase health services, I shouldn't be dive into poverty because I purchased health services that I need. So those are the three components of universal health coverage. And once you know this, you understand what a country should really try to do to make sure that everybody is covered, everybody has good enough health services, and they're not being impoverished while purchasing for those services. So this all sounds good, but how do we achieve it? Because all this is ideal, it sounds good and all, but how do we make sure that we achieve this? So this is where this term health financing comes from, and this is a quote that I thought would explain what health financing is, or what it does. Is health financing is fundamental to the ability of health systems to maintain and improve human welfare. At the extreme, without the necessary funds, no health workers would be employed, no medicines would be available, and no health promotion or prevention would take place. So you need money, or you need financial resources to make sure that the health system functions, and that's what health financing does. So the health financing basically has this function. If the function of a health system concerned with so the health financing is the function of a health system concerned with the mobilization, accumulation, and allocation of money to cover the health needs of the people individually and collectively in the health system. So this is basically what health financing as a function or as a field really focuses on. Make sure that it mobilizes enough funds, accumulates those funds, and then allocate those funds. And I'm going to go into the details about these three main functions of health financing, relating it to universal health coverage, and giving examples. So the three functions that we have just seen, we have revenue collection or revenue raising, fund pooling, and purchasing or provision of health services. And we're going to go into the details about each and every one of these three. So starting with the revenue collection slash raising, and the objective of this is make sure that the health system, or the whoever is managing the healthcare in the country, raises adequate revenues to make progress towards UHC, there is equity in finance. So this means that they have to make sure that the burden is shared fairly across society, and not only the sickest people are paying too much and the poorest are paying too much. There has to be equity in financing the healthcare system. And then they have to ensure stable and predictable flow of funds to the health sector. And we're going to go into this. So they are two main ways or categories of raising funds. And I guess the most common ones are direct taxes. So, the country taxes the population. So if you're working, there's payroll taxes. If you're a company or business, you pay taxes. So that's one way that the company or the country raises revenues. There's indirect taxes like VAT, non-tax revenues. These are like state-owned industries like oil companies or any other companies that are owned by the government. External grants, these are development agencies. And here you can think of non-governmental organizations like NGOs and other partners that are working into the country. This is very critical to low and middle income countries. And then there's external loans, which usually come from the World Bank, the development banks. So you have the World Bank, the African Development Bank, or the Islamic Development. There's so many different banks that countries can go to get loans, and this really helps when these loans are put into health. So these are ways that these are called public. Usually, this is the government raising the funds. So the other way would be private collection, revenue raising, and this includes out-of-pocket payments, and this is really important to note, because out-of-pocket payments, people usually think we have to pay for it but this is flat or fixed amounts that are paid at point of services. So if you go to a hospital and you pay a fee um, out of your pocket, then that's a private way of the health system raising funds to pay for services. All the voluntary health insurances, and these are usually common where you find people they purchase private or community-based schemes that you're insured through a private health insurance company, or you have like something in the community that you have a scheme where everybody pays into the scheme and then it covers you. So these are private, and they're usually not advised, because they end up directly taking money from the people. um, so in health financing, public collection of funds is better and is more stable, because it's predictable. So revenue raising is basically, it's not just about collecting money. A good financing system, you aim to raise sufficient funds, and you aim to provide financial risk protection to the population. And this means that you have to rely on public sources if you want to achieve UHC agenda, because private sources such as out-of-pocket payments and others really hurt the people who are the poorest. So that's revenue raising, and then we're going into, after raising all those revenues through taxes and grants from the World Bank and other development agencies, the country has money, or the Ministry of Health has money, whoever is managing the funds. Then how do you make sure that you're pooling these funds? And in this component of risk pooling, we're going to look at. So pooling is basically the accumulation of prepaid health revenues on behalf of the population for eventual transfer to providers. So on behalf of the population, the country or the Ministry of Health, or whoever is in charge of raising these funds, you accumulate these prepaid health revenues, and then on behalf of the whole population, and then you transfer them to providers. So the objective in this is making sure that there is equity in resource distribution, which means that the people who need care are able to get it whether they are able to pay or not. And we're going to come back to this and how it relates to UHC, because UHC says um, people should be able to access the services they need. It doesn't say anywhere whether they're able to pay for it. So if you need health services, you should be able to get them whether you're able to pay them or not. So that's the equity and resource distribution that the pooling does. And then there should be financial risk protection, which means that by sharing risk of potential high medical costs across the pool. So we're going to see that when you pool these funds, some people pay a lot, some people pay less. Some companies, big companies, pay probably uh, huge taxes, whereas some employee who's making not enough money pays, uh, a low amount of money. But the financial risk protection is that when you pay for that, in the future when you get sick, you protect yourself from paying a high medical cost. And this is kind of spread this high risk of paying high medical costs is spread across the pool. When you keep talking about pools and risk pools, you're going to hear this a lot in health insurance. What do they mean really? In this example that I'm going to give you is how do you do risk pooling? Um, so in this case, we're going to take insurance companies as risk pools, and this is basically how it works. Individual risk is hard to predict, but given a large group of people with certain known characteristics, an insurer or an insurance company is able to more accurately calculate the overall probability of an illness occurring within that group. And then that's how the premiums are based on average risk across the group. So basically, to explain this is the reason why people pay for health insurance or are in the pool is that you don't know when you're going to get sick. But if you know you have purchased some type of health insurance, you know that if you get sick, then you're going to be covered. But if you don't and you get sick, there's potential to pay really high amounts. But in order to do that, health insurance, this risk pooling, you look at the population, there's a lot of calculation that goes into it. There's people who go to school for this, but they're able to predict what types of complications are going to arise in this population based on the health needs of the population, and that's how the risk is done. But this next example is actually very simplified way of understanding this. So, for example, let's say there's 100 people, and once a year, one person at random gets sick and incurs costs of $2,000. So you have 100 people, and with the probability that that we have just seen, this probability of illness is that once a year, only one person randomly will get sick among the 100 people, and that the sickness is going to cost $2,000. And then you're worried that that person is random, it could be you. So worried about having to pay that much money, each person in the group decides to contribute $20 to a collective pool. So that's $20 times 100, which is 2,000, which is the cost of illness. If any of you is sick, when a person gets sick, their expenses are paid out of that risk pool. By paying $20, each person protects themselves from the potential 2,000 they would otherwise have to pay should they get sick. And I want to say this is a very simplified way of kind of like telling you what a risk pool is and why people do this. But basically, it's all about probability, and this is just a simple example. But you're one person in a pool of 100, but then if you don't pay this $20, you're going to end up paying the $2,000. So you opt to pay $20, which is a really low cost. And then when you get sick, because this is random, it's all probability, then you're covered at the end of the day. So that means that um, the 100 people are all covered because the probability shows that only one person will get sick. But because you don't know who, everybody only pays $20 and you solve the problem. So that's how risk pooling works. And that's why when we were saying here that you share the risk of potential high medical cost across the pool, that everybody pays a little amount and then everybody's covered. So what does a risk, a good characteristics of a good risk pool is basically made up, it should be made up of people with diverse health risks and socioeconomic status. So when a pool is done, you have to make sure that there are healthy people in the pool, there are sick people in the pool, there are rich people in the pool, there are poor people in the pool, because you want everybody to share that risk. If you have a pool that only has sick people, it usually tends the premiums go up because the companies are constantly having to cover for the medical cost of those that are sick. However, we see that a lot of countries usually don't go that route of making sure that the pool is composed of a very diverse population. So, for instance, many low-income countries tend to have separate pools for the formal sector versus the informal sector. And so basically here is when you have a country where people who work for the government or who are employed and they get, monthly salaries, they tend to have their own health insurance in a lot of low and middle income countries. And then the informal sector, so people who work in the informal sector are usually people who are not monthly, not on monthly salaries. So people who are um, merchant vendors in the markets or who have small shops, these usually tend to have their own separate pool. But that's usually a mistake, or it doesn't work well, because the people in the formal sector usually tend to be poorer. So their pool is going to be very resource limited as opposed to the pool where the formal sector is. So it's usually advised to not separate these pools, but it's also, it becomes political, and a lot of people don't want, like the formal sector usually don't want to mix with the informal sector, and it becomes complicated. This is also seen in some developed nations. So in the USA, there is a separate pool, for instance, for the elderly. So Medicare pays for people who are above the age of 65. And then there is Medicaid, which usually pays for the poor people who are under the poverty line. And this is really not a good pool because it's not diverse. Because when you have Medicare, for instance, you have a lot of elderly people. They tend to have more complications, and that doesn't share the risk across the population. And then if you have Medicaid, that's for the poor people, usually tend to have poverty is associated with more illnesses and stuff. So studies have actually shown that the US government usually pays a lot more money in maintaining these two, because they're separate, and the people in these separate pools are very high risk, at a high risk of contracting health complications. So the more diverse it is, the better. Um, One example that we can give is the United Kingdom or Canada, those countries that have a single payer system where, like for instance, in the UK, you have the National Health Services or the NHS, where everybody is automatically covered, and uh, taxes are you're taxed through the salary, and it goes into the government, and then everybody is covered regardless whether you're poor, you're sick, you're old, you're young. Everybody's under one pool, and that usually tends to work better for everybody because the risk is shared across the whole country, or the whole, in this case, the country is the pool. So, one of the things in the UK, the example that one of the things that you're going to see is that you automatically enroll into the pool. You don't have any option to opt out or opt in. And the reason why is this: participation in a pool should be compulsory and subsidized. So this is a quote from this Professor Victor Fuchs. Used to be a professor of health economics. He's now at Stanford. He used to be at Columbia, but he came up with this quote that's in his one of his papers, where he says no nation achieves universal coverage, or you can even say universal health coverage, without subsidization and compulsion. Both elements are essential, and the reason they're essential, he explains: subsidies without compulsion will not work. Indeed, they could make matters worse, since the healthy flee from the subsidized common pool only to return when they expect to use a great deal of care. And compulsion without subsidies would be a cruel hoax for the millions of poor and sick who cannot afford health insurance. And I guess I'm going to take a few minutes to leave this on the screen, but also to explain. So when you talk about subsidization, uh, is when, so usually when you have a pool like that, we have poor people and you have rich people in the pool. In the UK, we've seen that it's compulsory. Everybody has to be covered under the NHS, so that's compulsory. There's no question about it. But it doesn't mean that in those societies there are no people who are unemployed. So those people, usually they're unemployed or the poor. The government subsidized for them. So that's why where subsidization comes in. So that's why when he says, um, when you subsidize but without compulsion, a lot of the times you find that when it's not compulsory, young and healthy people usually don't pay for it. So you have to make sure that those people also pay into the pool. So that's why making it compulsory is the best way to go. And then if you make it compulsory but without subsidizing, that means the poor also have to pay because it's compulsory. So it's usually good to also subsidize for the poor. This is not only in the UK, like for example, in Rwanda, we have Mutuelle de Sante, which is a health insurance scheme that covers the informal sector, and everybody pays. They have people in their socioeconomic categories and people in the lowest category, which is the 25% of the population. They don't pay anything. The government subsidized for them, but everybody else is required to pay into the pool. So that's another example that shows that even low and middle income countries can take this lead. But because when you do this, you make sure that everybody is covered, both the poor and the rich, and the risk of health risk is shared amongst everybody, and everybody accesses care without suffering financial hardship. So, going to purchasing. So now you have raised revenues through taxes and other ways of raising money, and then you've pulled all these funds, making sure that everybody is in the pool, um, be, because you want to make sure that both healthy, rich, poor are all on the pool. So you accumulate all these funds and create a really diverse pool, and then now you're going to purchase services or provide services. So purchasing refers to the allocation of pooled funds to the providers that deliver healthcare goods and services. So the way you have this money, and then you made the pool of people, which is diverse. So now you're going to purchase or give this money to health hospitals, health centers, people who actually who have given care or delivered care. So there are two main categories of purchasing, and one is passive purchasing, which is basically you reimbursement of health providers without checking whether the consumed services were necessary. And then there's strategic purchasing, which allocates funds based on necessity and quality of care given. This is the one that improves performance and accelerates UHC journey. So in passive purchasing, you basically, a hospital comes to you as the Ministry of Health, or the person that's doing the finances at the Ministry of Health, and be like, oh, I have, let's say, 100 hospital beds, or I have admitted 1,000 patients this month. And the person who was at the ministry just pays for that without looking at whether the care consumed was necessary, whether even what they're saying is true. So it's just, you allocate money without checking. But in order to accelerate the UHC journey and make sure that everybody is covered, you have to make sure that the care was necessary and was of good quality, because one of the things we saw in the definition of universal health coverage is that care has to be of good quality. So in strategic purchasing, which improves performance, you make sure that, hey, you've come to me with this bill of you've received 1,000 patients. Was this all necessary? Was everybody treated, or are they all still in your hospital? Who has been successfully treated and going home? What's the percentage? And you kind of, based on that necessity and quality of care given, when you're allocating the funds. Purchasing, strategic purchasing, it's hard. Usually it takes a lot more resources. You have to have information, really a great deal of information, where passive purchasing is very easy and doesn't benefit the population or the purchaser. So, going in on strategic purchasing, when you're doing strategic purchasing, one of the things, there's a lot of things that it does, but I decided to focus on these two. So you emphasize on primary health care. We know that a lot of complications or health risks can be managed at the primary health care level, just because primary health care usually is less costly, and so the way you do that is making sure that primary health care funding is protected, and make sure that you pay relatively high amounts for PHC. So this is to incentivize people. So all the diseases that have been treated at the primary health care level, things like malaria or other diseases that can be managed at that level, you make sure that you give high amounts for those services, because to encourage people to treat these at the primary health care levels. Um, And the other thing that you try to do is use incentives to limit provision of expensive care. So, for example, co-payments for people who self-refer to hospitals, and it is frustrating sometimes for patients when you have a complication and you automatically feel like, oh, I need to go to the best hospital and get, you know, a scan or some type of really expensive care, where the pain you have or some complication you have could have been treated at the primary health care level. So one way of incentivizing people to not go to the higher levels of care, usually put co-payments so they pay more when they just go to those hospitals, or some part of payment to providers is linked to performance. For instance, I think a lot of people who have worked in healthcare, you've heard of performance-based financing. And for instance, in Rwanda, you make sure that the districts that performed well, there is some compensation that's linked to that, or the providers that are giving best quality of care, how are they performing, what's their results. So that's another way that you make sure that the quality is improved by using these incentives. So basically, when you're using strategic purchasing, you make sure that, although as frustrating as it is, because sometimes emergencies happen, but when people are sick, they tend to just go to higher levels of care with no apparent good reason. It, and in strategic purchasing, you try to limit a lot of the services at the primary health care level. This is not to say that people shouldn't go at the hospital or higher levels of care, but if necessary. So and then you have to make sure that those primary health care are invested in, they are good enough quality and so on, which this is all a challenge, and countries are always trying to improve their performances. But this is what a good strategic purchaser would do. So one examples I'm going to go through. uh, so most health systems, when they're not using strategic purchasing, end up paying for clinically ineffective medicines or services. So, for instance, in 2009, Medicare, which we saw, it's the insurance that covers the elderly people above 65 in the US, stopped paying for medical procedures from poor practice. So, for instance, falls from bed. If a hospital, if you find that in a hospital, and you would be surprised when this study showed thousands of falls from the bed. So that's reckless behavior or poor practice. And usually you end up, some people getting complications from these falls, especially since they're older. So the Medicare or this insurance doesn't pay for that if the reason of the injury came from this, because this poor practice. And then we often see these objects left in patients after surgery. And in this study, they found a lot of cases, in the thousands of cases of people having objects left in them, inside them after surgery. And if this is found to be the case, then there is no reimbursement for that service. So this is how, when you're doing strategic purchasing, you try to improve performance and quality of the services that are given. Another example, which is less dramatic, is that in Moldova, a study showed that there were variations in length of hospitalization for patients with uncomplicated diabetes. And there were like, oh, some people spending long hospital stays, others have lower hospital stays. Um, So what happened is that when you're doing strategic purchasing, since uncomplicated diabetes can be managed on an outpatient basis, so a strategic purchaser would opt for this option. So instead of keeping these people at the hospital or hospitalizing them when they have uncomplicated diabetes, then as a strategic purchaser, I would say, or instead of hospitalizing these people, since this complication, this health problem can be managed on an outpatient basis, let's have them come every Tuesday or Thursday for checkups and all that, but instead of giving them hospitals. So you see how when you're doing strategic purchasing, you actually internalize these procedures, you go into it and kind of look at how you can you can improve the performance and quality. So one other thing is the provider purchase. Sorry about that. Uh, one other thing that strategic purchasers try to do, or when you're doing this purchasing of health services, we know that it becomes complicated when the provider of health services is the same as the purchaser. And I'm going to explain a little bit. In some countries, you find that the Ministry of Health is the provider and the purchaser. So when that cause the Ministry of Health oversees the hospitals, the health centers, especially the public ones. And then if they are also the ones using their finance departments to provide or purchase the services, then that's not good. The accountability is low, and this leads to inefficiencies and low service quality, because if I am providing the services, that all these things that we saw of making sure that the performance is better, the quality is better, and I'm the one assessing that because I'm the provider and the purchaser. When I come to purchase things, I'm going to be a bit lenient because it's mainly the same person or the same institution. So it is advised to have a separate agency that purchase services. So for instance, the next slide, I'm going to show you the example of Rwanda, where we implemented this in 2015. So at the beginning, when we have Mutuelle de Sante, which is health insurance for the informal sector, it used to be managed by the Ministry of Health, but now, so so the MOH provides the services, and the RSSP, which is the Social Security Board, purchases the service. Since now the health insurance has been moved to the Rwanda Social Security Board. So the example is this. And this is like showing you this is a study that was done, and the from 2010 to 2015, as you can see on this graph, you see a decrease in subscription to the health insurance. There was a significant drop in subscriptions due to the mismanagement of funds by districts. So basically, the district hospitals used to manage these funds, and the district hospitals are the providers of services and the purchasers as well. So this was causing this inefficiency. So in 2015, Mutuelle de Sante, which is, as I said, the health insurance that covers the informal sector, was assigned to the Rwanda Social Security Board, and there has been a steady improvement. So you see when they made this move of splitting the purchaser and the provider, then you started seeing a steady improvement. So basically, this means that um, because the district hospitals don't manage it now, it's easier to make improvements, and the quality might have gone up as well, because uh, the RSSB isn't the Ministry of Health. So they're in a better position to come in and be like, hey, why are you doing that? That's not good enough quality, and we're not paying for that. As we saw things like Medicare examples and all that. So this makes sure that you're strategically purchasing, you're increasing the quality of services given, you're making sure requiring good performance, and that usually leads to better health outcomes, and it leads to to the country making their way forward towards universal health coverage. So basically, that's what health financing deals with. It's there to make sure that the country raises funds, accumulates those funds, and then purchases the services. The health financing field is a very big field, but this is a small session that gives you an overview what health financing is, what's the relation between health financing and universal health coverage, and a lot of you who might be interested in health financing, health economics. It's a very good field to dive into if you're really interested in the economics of health. So to end the session, I wanted to come back to this. A good health financing system raises adequate funds for health in ways that ensure all people can use needed services and are protected from financial catastrophe or impoverishment associated with having to pay for them. So this is very in line with universal coverage, because a good health financing system, we saw that component that I showed you at the beginning of the population component, of the service component, and then the financial component. And this is what a good health financing system does. I hope this session opened your eyes into health financing field and how it relates to universal health coverage. And yeah, feel free to email me or reach out if you have any questions. I know this is a very simplified way of learning health financing, but I think it gave you some really good examples to think about. So thank you and have a good day.